Hello everyone, Dr. David Warmflash here with a flash medical moment. Today's topic is cyanotic congenital heart disease. It's a really big topic, so let's get started. When we talk about cyanosis, we're talking about not getting enough oxygen to the tissues and therefore resulting in a lot of deoxyhemoglobin, causing this kind of bluish color to the skin. And if it goes on for a while, you can also get clubbing of fingernails. Plus, you also get bluish on the lips. And this comes from mixing of deoxygenated blood, meaning blood that has not been oxygenated through the lungs and has not dumped its CO2, mixing that into other blood. So you end up with some degree of deoxygenation. It could be anywhere from as deoxygenated as the blood gets. Venous blood is somewhere into 75 down to 70% of the hemoglobin oxygenated, and all the way up to 100%. If you put a pulse oximeter on when everything was working right, and you get close to 100%. We usually draw this in purple when there's any kind of mixing, and you know it doesn't go immediately from blue to purple to red. It's always along a spectrum, so let's just keep that in mind. Now, there are a few different types of cyanotic heart disease, and there's some classic types, and typically in a lot of instructional aids, they'll tell you, oh, to learn the cyanotic types of congenital heart disease, just remember that everything begins with a T, and then you can memorize all the T's. Well, they don't all begin with a T. So let's start with one that does not begin with a T. Pulmonic stenosis. This is a pulmonary valve that is just too narrow, so blood can't get through it. Why am I classifying that with cyanotic congenital heart disease? Because that can be a congenital condition, that the pulmonary valve is too narrow, and that always typically happens. There's something else going on. There might be some kind of a septal defect. There's some other way for blood to get out from the right ventricle other than going through the pulmonary valve, and that means that deoxygenated blood is going to mix into the circulation, and there'll be some kind of cyanosis. So don't memorize about the 5 T's. Don't ever really memorize with any of this stuff. Learn the concepts. Everything kind of fits together, and you can kind of get an idea how it works by understanding the physiology and the functional anatomy. How do you deal with pulmonary stenosis? Usually, if it's a severe stenosis, they can use a percutaneous method where a catheter goes through the femoral vein, goes up through the right side of the heart, and they can put a balloon in there and expand the balloon, open up the stenotic valve. That's called balloon valvoplasty. Now, pulmonary stenosis is one of the features of a very notorious, very famous cyanotic congenital heart condition, namely tetralogy of Fallot. This is named for Fallot, the 19th century French physician who first described 4 features. Remember, tetra in Greek is for 4, and there are 4 features. But as we'll see, they're really all part of the same problem. It's not that you just happen to get all these 4 things happening for a bunch of different reasons. It's all the same problem, really. One feature is that you do have pulmonary stenosis. You don't have either the pulmonary valve is kind of squeezed or it's stenotic, and you also have a ventricular septal defect, meaning there's a connection between the right and the left ventricles. You also have an overriding aorta, meaning that the aorta tends to be too much toward the right side of the heart. It's overriding the ventricular septal defect. So it can get blood from both ventricles. And so what's happening? Not enough blood is going into the pulmonary artery, and the aortic valve is getting really blood from the right and the left, and there can be different degrees of how much is pushed over. And the other thing that happens is because this all increases the pressure in the right ventricle, you get right ventricular hypertrophy. That's the fourth feature. They're all really related because what's causing all of this is that the entire the middle of the heart, which is supposed to be where the ventricular septum comes from, it's all sort of pushed over toward the right side of the heart, and that kind of squeezes in the outflow to the pulmonary valve, and also pulls the aortic valve over toward the right, and causes the other problems, namely that there's a ventricular septal defect because part of the septum, the membranous part, gets pulled over and you have an opening, and that means you got right ventricular hypertrophy, and therefore you have all four features like that. Isn't that interesting? Who gets this? There are a few different risk factors that you should know. There are many risk factors. Let's just name a couple of them. Maternal diabetes, meaning pre-gestational diabetes, in contrast with gestational diabetes. We're not talking about the diabetes that happens only during pregnancy, but the kind that's present outside of pregnancy also. So think of it as maternal diabetes, even when she's not pregnant. That's a risk factor. Infectious diseases, various viruses, such as rubella virus, and there are also chromosomal anomalies. One really classic one is DeGeorge syndrome. That's where there's a microdeletion of the long arm of chromosome 22, and you've got a constellation of things that happen in DeGeorge. One being that there's either no thymus at all, so there are infectious disease problems, or the thymus is just extremely atrophied or never really developed, so not much of a thymus. You also have hypoparathyroidism, so you'd have low calcium, and you got a few of these possible cyanotic congenital heart conditions, one of them being tetralogy. You can really go on for hours and hours on this. Let's just go through a few things that happen. Why is it cyanotic? It's cyanotic because there's not enough outflow to the pulmonary artery, and the aorta is overriding, at least partly, the right ventricle, so more blood than only the left ventricle blood goes into the aorta and through the body. So you get mixing of deoxygenated blood into with the oxygenated blood. You don't necessarily have the cyanosis at birth. So sometimes, actually, tetralogy is not the most common cyanotic congenital heart condition at birth. It is the most common cyanotic congenital heart condition overall. But sometimes it takes a while for this to develop as all the dust is settling and things are adapting to the post-birth situation. Because things have changed. Things have changed since the fetal circulation. All right. Now, what are some of these important features to remember other than cyanosis is TET syndromes. TET syndromes, and you can remember TET because of tetralogy. And this is when there's a sudden episode of severe cyanosis and the baby is crying. It could be set off by crying. And very often the baby learns to correct this by squatting. You know, what happens when a person with tetralogy squats is that it squeezes the femoral arteries, and that increases the afterload, so the pressure will go up in the left side of the circulation, and that kind of discourages blood from going through the aorta, because really the aorta is in competition with the pulmonary artery, and so more blood than normally would go through that stenotic pulmonary valve, because now it's harder to get into the aorta. And that's actually one way of testing it. You can have the baby or make the baby squat, and the cyanosis would get better. How does the baby learn this very sophisticated pathophysiology and physiology? Oh, I can increase my afterload if I squat. No, it's trial and error. Oh, I squat, I feel better, and that's what happens. That's really the issue. How do you deal with this? It's surgery, and sometimes there are a few different stages. You have to do one correction, another. First, correct the outflow to the pulmonary artery, open up, make it possible surgically for blood to get in to the pulmonary artery, and then you can work on the septum. Well, let's talk about another cyanotic congenital heart condition. Let's talk about truncus arteriosus, really also known as persistent truncus arteriosus. The truncus arteriosus is one big fat blood vessel coming out of the heart. And guess what? That's totally normal during embryology. That's actually how the great vessels start out. You start off, the heart is just a few blood vessels coming together. But during embryology, the truncus arteriosus, which also comes from a valve called the truncal valve, one big valve, it's supposed to divide up. But in the persistent truncus arteriosus, it doesn't divide up. And you also have a big ventricular septal defect, because really what happens is that the whole circulation is supposed to divide up between left and right, and it really doesn't do that so well with truncus arteriosus. So you got a ventricular septal defect, and you have an undivided trunk, which then a little more downstream, then it divides into aorta and pulmonary artery. But you already have all this mixing, and that's why it's cyanotic. Who gets this? Well, same kinds of risk factors. You get certain viral infections in the mother, alcohol, as well as DeGeorge syndrome. In fact, DeGeorge syndrome accounts for something like 1/3 of all the cases of truncus arteriosus. So there's kind of a pattern here. Also, with a lot of these congenital heart conditions, both acyanotic and cyanotic, Down syndrome is in there. That's when there's 3 chromosome 21s. Well, you need surgery for this, just like you need surgery with tetralogy. Let's talk about a few findings. You get murmurs and things on the physical exam, as you might expect. With chest x-ray, even though these are diagnosed really by echocardiography, and if you really want to get into detail, like getting ready for surgery, there's also cardiac MRI and things like that. But there are some classic findings that they will ask you on exam on the chest x-ray. On tetralogy, it is a boot-shaped heart. The heart looks like a boot, which you can see here on the visual. And on electrocardiography, we should also talk about that. On tetralogy, what do you think would happen on ECG? Well, you've got a hypertrophied right ventricle, which you also have that actually in truncus. And anytime you've got a hypertrophied right ventricle, what might that cause? You might have right axis deviation, because it's so hypertrophied, and you're getting a stronger signal in the leads to the right. Well, let's talk about another cyanotic heart condition, congenital heart condition. Let's talk about transposition of the great vessels. Remember, I said that even though tetralogy is the most common cyanotic condition overall, it's not the most common cyanotic congenital heart condition at birth. That would be transposition. This is a really weird one. See, normally when the great vessels are developing from the and along with the heart, there's a kind of a twisting maneuver, and the twisting doesn't happen, or it doesn't twist as much. And what happens is you end up with the pulmonary artery coming out of the left ventricle and the aorta coming out of the right ventricle. That's pretty bad. So in other words, instead of having this kind of figure eight pattern of the circulation where you got things going through the lungs before going through each circuit, after the right circuit and before the left circuit, you got like two circles. You have blood coming into the right atrium, going into the right ventricle, going into the aorta, going through the systemic circulation, coming back again to the right atrium. Whoa, it didn't go through the lungs. And on the other side, you got the left side, you got blood coming in from the lungs into the left atrium, which is where it's supposed to come in. But then after it goes into the left ventricle, it goes into the pulmonary artery, back again through the lungs to get oxygenated. You don't need to get oxygenated again. You need to get into the body. How could a baby be born with this and be alive if no blood that's going through the body is even getting any oxygen? Well, the answer is there are some connections. There are shunts, because during fetal life, there are connections. There's the ductus arteriosus connecting the aorta and the pulmonary artery, and there is the foraminal valley connecting the left and right atria. And you want these to be open after birth. Now, in modern times, you're going to know that there's not truncus arteriosus, but you would know about that too. You're going to know about any of these conditions, and you're going to know about transposition occurring in the fetus. You're going to be ready for this. And one thing you really want to do is you want to keep the ductus arteriosus open. You want to maintain a PDA. So you can even start that even before birth. How do you do that? Well, what makes the ductus arteriosus close? Remember how in pregnancy, the woman is not supposed to take NSAIDs during the late part of pregnancy, because that would cause premature closure of the ductus arteriosus, which would be really bad. What keeps it open is prostaglandins, and you can start giving prostaglandin E1 even before birth, and you can have an infusion of that also after birth, and that'll keep the ductus arteriosus open until you can then work on the surgical correction. And boy, do you need surgical correction on this. The great vessels have to be switched around eventually, but in the meantime, you absolutely must maintain these shunts. Let's just talk about, now, as I said, there are a whole bunch of these conditions. There's a weird one called total anomalous return, where the pulmonary veins actually come into the right atrium. That's really bad. Let's talk about another one called tricuspid atresia. Atresia means that the valve didn't really develop well at all. There's practically no valve. And what you have in between the right atrium and the right ventricle is basically just the septum. You have a wall there. You have no way for the blood to get from the right atrium into the right ventricle. And so in utero, the right ventricle kind of atrophies. It kind of withers away its own myocardium, and you don't really have a very good right ventricle. So you might say, oh, couldn't the surgeons create a kind of artificial or put in a tricuspid valve? But the problem is you don't even have a good right ventricle in there. How would the baby be alive? Because of other connections. You almost certainly will have an atrial septal defect, or you will have a ventricular septal defect, or you will have a patent foraminal valley that will most certainly stay patent. And you want to try to keep that ductus arteriosus open if you know you're going to have this, because the correction for this has to come very gradually over a period of a few years. And what they do in cases of tricuspid atresia is gradually transform the child into a single ventricle physiology. And what that means is we're going to throw up our hands and say, that's it, we're just resolved. We're not using that right ventricle. It's kind of useless anyway as a pump. The only thing for which we're going to use the right ventricle is as a passageway to get blood from the left ventricle to the pulmonary valve, because the pulmonary valve is okay. The problem is the tricuspid, it's just not there, and you don't have much of a right ventricle. So if there is no ventricular septal defect, they're going to have to create one eventually. But what they do typically very, very soon after birth is they have to maintain the ductus arteriosus, which you could do with prostaglandin E1, but you need more than that. You need another way for blood to move between the two sides of the circulation. So they do something called a Blalock-Taussig procedure. And these are all named for really famous surgeons that have a really interesting history. Blalock, a really fascinating career. And what the Blalock shunt does, Blalock-Taussig shunt, is it connects the arterial blood, usually a little bit downstream from the aorta itself, like such as the subclavian artery, connect that to one of the pulmonary arteries, and you're going to get more blood shunting in from that arterial system into the pulmonary system from the aorta. Then when the child's a little older, something like 6 months or several months, or a year, really it's done more close to a year, they're going to start in with procedures called Fontan procedures. And you don't do it all at once, but what a Fontan procedure is, and there are different variations on this, is a kind of procedure that bypasses blood around the right side of the heart. Don't even send it through the right ventricle. So the venous return that's coming in, you're going to send that directly to the lungs, avoiding the right side of the heart altogether. And they do a hemi-Fontan at first, at about a year of age. And what that means is you create a channel, a passageway from one of the vena cava, superior or inferior. Usually they'll do it first with the superior vena cava, the SVC, and create a canal from there to the pulmonary vasculature, such as to the right pulmonary the right pulmonary artery, or the pulmonary artery itself. And that's going to take a lot of the venous blood, send it right through the lungs. Then, a few years later, close to 4 years old, 5 years old, they're going to complete the Fontan physiology by doing the other part of the other hemi-Fontan, making it a full Fontan. And then they would say, make a connection from the IVC to the pulmonary arteries. And what's happening now is that all the blood is now just missing the right side of the heart. All the blood now is missing the right. All the blood now is missing the right side of the heart. It's getting detoured around it, and basically you've got a single ventricle heart. You have blood coming from the venous return, the IVC, the SVC, going directly through the lungs through passive It's just moving passively through them. There's no pump as you would normally have from the right ventricle. Comes back through the pulmonary veins right into the left atrium, and that gets pumped through the body. But when it gets pumped through the body, it continues all the way through the lungs. That's a Fontan procedure, and that's what's done in tricuspid atresia, and it's used for certain other situations too. This is just a broad overview on cyanotic congenital heart disease. There's a lot more to it, but it should give you the basic idea, and that's it for the lesson today.